Right now, somewhere in America, a 73-year-old man is swallowing a small white pill with his morning coffee. He has taken it every day for 4 years. His blood pressure numbers look acceptable. His doctor is satisfied. He feels fine. And his kidneys are failing. Not from his blood pressure, from the pill he takes to control it. I want to tell you something that stops most people cold when they hear it for the first time. Kidney disease from blood pressure medication does not hurt. There is no aching, no burning, no warning signal your body sends you. By the time most people find out there is a problem, they have already lost a significant portion of their kidney function permanently. And once kidney function is lost, it does not come back. My name is Dr. Elena Russo. I am an internal medicine physician, and I have been practicing in New Jersey for over 25 years. The reason I am making this video is simple. I have watched this exact pattern unfold in patient after patient. Different names, different cities, different doctors. The same silent outcome. There are 4 specific blood pressure medications I need to walk you through today. And before we get there, I need to tell you about something nephrologists, that is, kidney specialists, have a name for. They call it the triple whammy. You will understand exactly what that means by the end of this video. And you will never look at your medicine cabinet the same way again. Before we get into the specific medications, I need you to understand one biological fact. Without it, nothing I am about to tell you will land with the weight it deserves. After the age of 40, kidney function declines roughly 1% every year. Silently, without symptoms. By the time a person reaches 65, they have already lost approximately 20 to 25% of the kidney capacity they had at 40. By 70, that number can reach 30% or more. This matters enormously when we talk about medication, because every blood pressure drug on the market was tested and approved in populations that included far younger adults. The safety data was built on kidneys running at full capacity. When that same drug reaches a 68-year-old kidney operating at 70%, the math is completely different. Think of it this way. Imagine a water filtration plant running on full staffing. Now cut the staff by a quarter and keep the workload exactly the same. That plant will still function, but there is no longer any margin for error. Any additional pressure on the system, any reduction in supplies, any demand spike, and the whole operation starts to crack. That is the kidney you are working with after 60. And some of the most commonly prescribed blood pressure medications in America are not just failing to help that kidney. They are quietly making things worse. Right now, think about your blood pressure medication. If you are not sure whether it is a diuretic, an ACE inhibitor, or something else entirely, write the name in the comments. I read every one, and I want to help you understand what you are taking. The first medication on this list will surprise you because diuretics have been a cornerstone of blood pressure treatment for decades, and for most patients, they do bring numbers down. I am not disputing that. What I am telling you is the part nobody explains at the pharmacy window. Diuretics, and that includes hydrochlorothiazide, furosemide, and chlorthalidone, work by forcing your kidneys to flush out extra sodium in water. They reduce blood pressure by reducing the fluid volume in your circulatory system. Mechanically, this makes sense. Here is what is happening underneath. When you put a diuretic to work, you are running your kidney's filtration system at full throttle. You are asking the renal tubules, the tiny filtering channels inside the kidney, to push out more fluid, constantly, every day. For that process to work safely, the kidneys need adequate hydration to do the job. They need water to filter water. And here is the problem. Research shows that approximately 40% of adults over 65 are chronically underhydrated, often without realizing it. The thirst mechanism weakens with age. Many seniors also limit fluids deliberately, specifically to reduce bathroom trips. The result is that a significant portion of people who begin a diuretic are already running dry before the drug adds its own demand. An overworked filtration system without enough fluid is not a minor inconvenience. Think of an engine running without enough coolant. It overheats. Your renal tubules do something similar. They become concentrated, stressed, and over months and years, this sustained stress contributes to a condition called chronic kidney disease, in which the kidneys gradually and silently lose their ability to filter waste from the blood. What makes this particularly painful is that most of these patients are doing everything right. They are taking their medication. They are going to their appointments. Their blood pressure readings look good. Nobody is watching what is happening to their kidneys in the background. I want to tell you about Barbara. She was 72 years old, a retired school librarian from Columbus, Ohio. She had been on hydrochlorothiazide for blood pressure for 3 years. In that time, she had quietly developed a habit of limiting fluids during the day to avoid interrupting her book club meetings and afternoon walks. She was never told, not once, to increase her water intake while on a diuretic. When I reviewed her labs, her creatinine had been creeping upward for 2 years. Nobody had flagged it as medication-related. When we talked through what was happening and why, she looked at me and said, "I thought I was being careful. I didn't know careful was making it worse." If you are on a diuretic, daily hydration is not optional. It is protective. 6 to 8 glasses of water per day, minimum. And if you have been on a diuretic for more than 12 months without a kidney function test, that is a conversation to start at your very next appointment. But the second medication on this list surprises people even more, because it is in a category most doctors consider kidney protective, until it is not. ACE inhibitors are among the most prescribed medications on earth. Lisinopril, enalapril, ramipril. You almost certainly know one of those names. And for the majority of people who take them, ACE inhibitors are safe, effective, and genuinely beneficial for the kidneys over the long term. Here is the exception that your doctor may not have checked you for. It is called renal artery stenosis, a narrowing of the arteries that supply blood directly to your kidneys. This condition is more common in older adults. It is more common in people with atherosclerosis, and it causes absolutely zero symptoms on its own. You can have moderate renal artery stenosis and feel perfectly healthy because the kidneys, just like the heart, compensate quietly until they cannot anymore. Now here is the mechanism that matters. Your kidneys depend on a certain level of internal blood pressure within their own tiny vessels in order to filter blood properly. When those vessels are healthy and open, ACE inhibitors reduce that pressure in a manageable way. But in kidneys fed by narrowed arteries, reducing that pressure is like trying to push water through a partially kinked hose. Almost nothing gets through. The filtration rate drops. The kidney begins to accumulate damage, silently, appointment after appointment. The research on this is well established and deeply uncomfortable. ACE inhibitors can induce acute kidney dysfunction, specifically in patients with significant renal artery stenosis, because the medication eliminates the pressure compensation mechanism the kidney was depending on to function. The narrowing was already there. The ACE inhibitor did not cause it, but it removes the safety valve that was keeping things stable. I think about Raymond often. He was 70 years old, a retired civil engineer from Phoenix, Arizona. He had been on lisinopril for 3 years. His blood pressure numbers looked excellent. He felt well. At a routine blood panel, his eGFR had dropped to 56. His internist investigated and found moderate renal artery stenosis that had never been detected. The lisinopril had not caused the narrowing, but it had been quietly stressing those narrowed vessels for 36 months without a single warning sign. His medication was adjusted and his kidney function stabilized. But Raymond said something to me that I have never forgotten. He said, "My doctor did everything right. So did I. And my kidneys were still losing ground the whole time." If you have been on an ACE inhibitor for more than 6 months and nobody has monitored your kidney function through a creatinine and eGFR test, that is something to bring up before your next appointment ends. If your kidney numbers have shifted on any blood test, ask your doctor specifically about a renal Doppler ultrasound, a non-invasive test that checks blood flow to your kidneys directly. Have you ever had your kidney function tested while you have been on a blood pressure medication? Yes or no in the comments. Because what I am about to tell you next changes the stakes of that question completely. The third medication on this list is not a prescription drug. That is what makes it so dangerous. Ibuprofen, naproxen. The bottle in your cabinet you reach for when your knees ache or your back tightens up. The pill that has always worked for arthritis pain. The thing you have been taking for years, possibly alongside 1 or 2 blood pressure prescriptions, without anyone ever connecting those two facts. More than 40% of adults taking blood pressure medications also regularly take ibuprofen or naproxen for pain. 3 separate surveys, 3 different populations, consistent finding. These are not unusual patients making unusual choices. This is the ordinary, predictable overlap between 2 very common problems in older adults: high blood pressure and chronic pain. Here is what happens inside the kidney when those drugs meet. NSAIDs, non-steroidal anti-inflammatory drugs, block compounds called prostaglandins. Prostaglandins do many things in the body, but one of their jobs is to regulate blood flow through the delicate vessels inside kidney tissue. When you block them, those vessels constrict. Less blood flows through. Less waste gets filtered out. In a young, healthy person, this is a short-term, mild effect that reverses when the drug clears. In an older adult, already on a diuretic that is reducing fluid volume, the picture changes. Add an ACE inhibitor that is reducing internal kidney pressure on top of that, and now add an NSAID that is constricting kidney blood flow, and you have created what nephrologists have a clinical name for: the triple whammy. This is not a phrase I invented. It was identified in the medical literature in the year 2000 and has been extensively studied since. A landmark 2013 study published in the BMJ, examining nearly 500,000 patients followed over an average of 6 years, found that people taking this triple combination, a diuretic, an ACE inhibitor or ARB, and an NSAID, had a significantly elevated risk of acute kidney injury. The highest risk occurred within the first 30 days of combined use. What I find most disturbing about this pattern is not that it is unusual. It is that it is ordinary. Nobody is deliberately taking 3 kidney-damaging medications. They are taking a prescribed blood pressure pill, another prescribed blood pressure pill, and a painkiller they have used for knee pain for years. Their cardiologist prescribed one, their internist prescribed the other. They picked up ibuprofen at the grocery store because it always worked. 3 separate decisions, 3 different providers. One silent problem building in the kidneys month after month. Let me tell you about Donald. 74 years old, a retired electrician from Nashville, Tennessee. His cardiologist had him on lisinopril. His internist had him on hydrochlorothiazide. He had been taking ibuprofen 3 or 4 times a week for hip arthritis for 6 years. An over-the-counter decision nobody had ever asked about because nobody had the full picture. At a routine blood panel, his eGFR was 52 and trending downward. When we switched his pain management to acetaminophen, optimized his hydration, and his providers finally had the complete medication picture in one place, the decline stopped. Donald looked at me and said, "Nobody ever asked me what I was taking on my own. I didn't think it counted." Acetaminophen does not carry the same kidney-constricting mechanism as NSAIDs, and is generally the safer daily choice for seniors managing chronic pain alongside blood pressure medications. Topical NSAIDs, like diclofenac gel, applied directly to a painful joint, are absorbed locally with significantly less effect on the kidneys overall. But what makes the triple whammy truly dangerous is something we have not fully addressed yet. Because the most dangerous situation is not the one where you happen to be on all 3 medications. It is the one where nobody, not one doctor, not one pharmacist, has done the math on your behalf. And that is what we are going to talk about now. The average American over 65 takes 4 or more prescription medications daily. Many take 6, 8, or 10, a combination of prescriptions, over-the-counter products, and supplements, often prescribed by multiple different doctors who may not have full visibility into what the others have recommended. Here is what that means for the kidneys. Each medication in isolation might carry a manageable risk in a healthy organ. In a 68-year-old kidney already running at 70% capacity, that margin for error does not exist. And when multiple medications with kidney-affecting mechanisms overlap in the same body simultaneously, the risks do not simply add. Research suggests they can compound in ways that no single provider looking at a single prescription would ever predict. The problem is structural, not individual. It is not that any one doctor made a mistake. It is that the person sitting in front of those doctors, the patient, is the only one who sees every piece of the puzzle at once. And they were never told what to do with that information. I see this pattern in practice far more often than anyone in the medical system wants to acknowledge. A patient whose nephrology workup looks alarming. A set of kidney numbers trending in the wrong direction. And when you sit down and go through everything they are taking, prescription by prescription, over-the-counter drug by over-the-counter drug, the picture finally becomes clear. The triple whammy was there the entire time, in plain sight, invisible only because nobody had assembled the complete list. This is the fourth danger, not a specific medication. A gap in care so common and so consequential that I consider it the most underreported driver of silent kidney damage in the senior population today. Here is what you actually do with this information, starting this week. Step 1. Write down every single thing you take. Prescription medications, over-the-counter drugs, supplements, pain relievers, sleep aids, everything. Do not leave out the ibuprofen you take occasionally for knee pain or the antacid you use every morning. Everything goes on that list. Then bring that list to every single doctor's appointment. Every one. Because the dangerous combinations we have talked about almost always develop because no single provider has the complete picture at one time. Step 2. Ask specifically for a creatinine level and an eGFR test at your next appointment. If you are over 60 and on any blood pressure medication and have not had this checked in the past 12 months, write this sentence down and use it. I would like to check my creatinine and eGFR to make sure my blood pressure medication is not affecting my kidneys. Your doctor will know exactly what to order. Step 3. Know your eGFR number and what it means. Above 90 is normal. Between 60 and 89 suggests mild decline. Below 60 indicates moderate chronic kidney disease. Below 30 requires urgent medical attention. Ask your doctor what your current number is and, just as importantly, what direction it has been trending over the past 2 years. Step 4. If you take ibuprofen or naproxen regularly alongside blood pressure medication, have a specific conversation about alternatives before your next dose. Acetaminophen. Topical diclofenac gel. Your doctor can help you find the right option for your specific situation. Step 5. If you have been on an ACE inhibitor for more than a year and have never had any imaging of your kidney arteries, ask whether a renal Doppler ultrasound is appropriate for your situation. This is especially worth discussing if your kidney numbers have shifted on any recent blood test, or if your blood pressure has remained inconsistent despite medication. And the triple whammy, the 3-drug combination that nephrologists have been warning about for over 2 decades, is the single most important thing on this list to bring up by name. I want to make sure I am not in triple whammy territory with my current medications. That phrase alone will tell your doctor exactly where to look. One share of this video might be the most important thing you do this week. Someone you love is probably taking one or more of these medications right now, and they have never heard the words triple whammy in a conversation with their doctor. I want to close with a patient I think about often. Her name is Shirley. She was 76 years old, a retired piano teacher from Allentown, Pennsylvania. She had been managing her blood pressure for years, taking her medications faithfully, going to her appointments, doing everything she was supposed to do. She felt well. She was active. She still gave weekly piano lessons to neighborhood children. She was referred to me ahead of a planned knee replacement. Routine preoperative blood panel. Her eGFR came back at 41. Surgery postponed. Nephrology consult. We went through her complete medication list together for the first time. Everything. And the picture became clear immediately. She was on a diuretic. She was on an ACE inhibitor. She had been taking ibuprofen for knee pain multiple times a week for years. Nobody had ever assembled those 3 facts in the same room at the same time. Over the following 18 months, with careful medication adjustments, consistent monitoring, and a switch to acetaminophen for pain, Her eGFR stabilized at 46. Not a full recovery. Kidney function rarely fully recovers once lost. But the decline stopped. The knee replacement happened. Shirley is still teaching piano at 76. When she came back for her 6-month follow-up, she said something I want you to hear. She said, "I thought being on my medications meant I was taking care of myself. I didn't know they could be taking care of each other instead of taking care of me." That sentence is exactly why I made this video. Your kidneys have been working for you, silently, every single minute of every day you have been alive. They do not ask for much. Adequate hydration, a complete medication list that one doctor has actually reviewed in full, and the awareness that the triple whammy is a real, named, documented clinical risk that you can ask about by name at your very next appointment. That call, that one conversation, may be the most important thing you do this month. If this video helped you, subscribe so you don't miss what we are covering next. What we talked about today protects your kidneys, but the arteries that supply those kidneys, and your heart, and your brain, are a separate story. There is a specific compound that the research says addresses arterial health at the structural level, in ways that most physicians have never discussed with their patients. Not a medication, not a statin, something that works through a completely different mechanism. That is the next video. It is coming very soon, and you will want to watch it while what you have learned today is still fresh.